Commissioner. Well, good morning, everyone. I'm County Commissioner Josh Parsons. I want to welcome you back to Joining Forces, and thank you for joining us. This is our virtual Lancaster County Joining Forces Forum. Again, we just appreciate you taking the time to join us this morning. As a reminder, as we've done in the past, right now participants are in listen-only mode, but we do encourage you to use the chat box at any point throughout today's session. And moderators will be monitoring that chat box all morning to assist you and answer any questions you have. As you all know, and as you've lived, Lancaster County continues to weather the impacts of the overdose epidemic and the COVID-19 pandemic. These crises have led to challenges, but it's also allowed accessibility to services and supports through telemedicine. This is not ideal for every individual, but telemedicine did make it easier for many individuals to stay engaged in treatment throughout the pandemic. The pandemic also showed us that we have an incredibly resilient community, which we knew in Lancaster County, but it's definitely showed that. We were able to pivot to prevent gaps in services and support individuals and families seeking help for addiction recovery supports. So we should take a moment and really celebrate our collective success over the past 18 months and the things that this community has done well, which are many, many things. As we typically do during our community forums, we'll begin today with a data snapshot of Lancaster County, which will include data around overdose deaths and also risky prescribing rates. After that, we'll hear from a group of panelists who will share their perspective about challenges and opportunities that the overdose epidemic and the COVID-19 pandemic have brought to light. We'll also have time for questions and answers this morning, and please put any questions you have in the chat box at any time. Moderators will be monitoring that chat box. If there are any questions that we're not able to get you this morning, our moderators will work through and get your questions answered after the event. So again, thank you for joining us. Thank you for your efforts over this challenging last 18 months. And at this time, I'm going to throw it over to Brenda Boucher, who will, as usual, provide what I think is one of the most important parts of our mornings, which is the data update. So thank you.
Hey everyone, I'm sorry I can't be with you in person today, but I am going to run through some slides for you to give you an update on our outcomes data that we watch, as well as some of the data that we have on interventions that we're using. I'll walk through the data that we have on overdose deaths and emergency department visits, demographic risks, substance risks, and some of the prevention strategies, use of naloxone, risk reduction, and treatment. This slide shows the overview of the number of overdose deaths we've had in Lancaster County, going back to 2010 and coming up to what we have reported for this year to date. So we had the exponential increase in overdose deaths starting in 2015 that continued through 2017. Then we had a pretty sizable decrease in deaths in 2018, 2019, and then another increase again last year. In 2021 to date, we have 82 deaths so far, and that's about the deaths that have been reported through the end of July or so. Lancaster County was not alone in having an increase from 2019 to 2020. The US in general and Pennsylvania also did. So this slide shows that in the US, there were more than 90,000 overdose deaths in 2020, and that was an increase of 30% from 2019. In Pennsylvania, we had more than 5,000 overdose deaths. That was an increase of 16% from the previous year. And in Lancaster, as we saw before, we had 146, and that was a 40% increase from 2019. It's also important to note about this that the US numbers and the Pennsylvania numbers are only provisional, which means that they're not final and may change. This slide shows the cumulative overdose deaths by month going back to 2017 and coming up to what we have for 2021 so far this year. On this chart, the top purple line is 2017 data. That was when we had the most overdose deaths. The lowest line is 2019. That was in the past few years, the lowest number that we had. And you can see that for 2021, which is the brown line on this chart, we started out the year quite high in terms of deaths. We had numbers that were higher than most years that we've had in the past few. Since then, the numbers have come down a little bit, but we're still trending higher than we have the past few years. And again, we don't necessarily have all of the data reported from June and July, so it's still really too early to tell. This chart shows emergency department visits for opioid overdoses in Lancaster and in the state of Pennsylvania overall. So Lancaster is pink, or the lighter colored line, and Pennsylvania is red, or the darker colored line. So per capita, per 10,000 population, Lancaster has fewer emergency department visits for opioid overdoses. And there's really not much of a trend to this line. It goes up and down quarter to quarter, but there wasn't much of a trend until towards the end of 2020 and the beginning of 2021. There was a decrease in Lancaster in the number of emergency department visits. And that was when we had our highest number of COVID cases. And so that may have contributed to that. In the second quarter of 2021, on the far end of this chart, there's a little bit of an increase, which may be good. It may demonstrate that people are feeling a little bit better about going to the emergency department if they need to. The next few charts show the rates of overdose deaths per population for different demographic groups. So this first chart is age group. And what you're looking at is each group is a different line, and that shows the rate for that age group. And then on the far side of the chart, there's a percentage. That's the percentage increase from 2019 to 2020 for that particular group. So there are two things to look at on these charts. The lines, or the groups that are at the top of the chart, have the highest rate of overdose death for their population size, which means they're at the greatest risk. So in this case, that is the age group 25 to 34 and 35 to 44. We can also look at that percentage increase to see who might be at changing risk from 2019 to 2020 and think about what might have happened for that particular group. So for this chart, the age group 45 to 54 and 35 to 44 both had 100% increases or more, which means that the rate more than doubled in that population. When we look at the deaths by sex, again, so the top line on this chart is the rate for males, and the bottom line is the rate for females. So that means that males are more at risk. They have more overdose deaths for the size of their population compared to females. And then when we look at the percentage increase, there was more of an increase for females from 2019 to 2020. They had a 63% increase in the death rate versus 31% in the male group. This is the rates by race. And here, both risk factors kind of point in the same direction. So to make the numbers meaningful, the Department of Health groups together all people of color in a group so that there's enough numbers. And so compared to the white population, people of color have a higher rate of overdose deaths for the size of their population. And also you can see that they had a more significant increase in that rate from 2019 to 2020. And then finally, this chart looks at people who identify as Hispanic or Latino versus not. And in this case, people who are Hispanic are at higher risk, but their risk stayed exactly the same from 2019 to 2020. So that might be something interesting to think about. What are the risk factors in that population that put them at higher risk, but maybe didn't get worse during the pandemic or in 2020? These are some slides about risk factors based on substances. So this chart shows how many deaths, what percentage of overdose deaths included each of these substances. And this data goes up to what's been reported through August of 2021. So the first substance there is fentanyl, and by far the biggest trend we've seen in the types of substances is that fentanyl has increased dramatically in overdose deaths. Heroin has decreased over time. We also had seen a decrease in prescription opioids in overdose deaths, but that increased again in 2020, and in 2021 is sort of trending along the same direction. In this chart, you can see that benzodiazepines have decreased as a percentage of being present in overdose deaths. Cocaine has remained about the same over time. Ethanol, alcohol, about the same. And then other illicit drugs includes primarily methamphetamine and amphetamine, and those have increased, as you can see, going back to 2015. The next few slides are about prevention strategies and interventions. So this chart shows the reported use of naloxone in the county going back to 2017 by EMS in the dark purple, law enforcement in light purple, and then Good Samaritans a little bit in the teal color for what we have reported from Good Samaritans. 2021 data is reported up through the end of June, so that's half of the year. So EMS administration of naloxone increased quite a bit in 2020. So if you think about how many deaths we had back in 2017, which was the peak, we clearly have a lot more EMS on the scene using naloxone in 2020, which is good. It either means that EMS are more used to responding to overdoses, having naloxone, people are more likely to call them to the scene, or both. I think it's also important to note in this chart that all of these are situations where somebody is at risk of dying of an overdose. And so when you think about the numbers of deaths in context of these numbers, we have between 100 and 200 deaths for all of these years. There are a lot more situations where people are at risk of dying and do not die because they had someone there who could provide naloxone. The next two charts are about prescription drugs and the risk posed by prescription drugs. So this chart is by quarter going back to 2016, and it shows how many people have a high dose of prescription opioids. So this is one of the ways we define risky prescribing. And this shows, again, Lancaster versus the state of Pennsylvania. So Lancaster is the light pink line and Pennsylvania is the dark pink or red. And both have trended down quite a bit over time. So the rate of people who have this sort of risky high level of opioid prescription has gone down a lot over the past 4 or 5 years. Another risky prescribing issue practice is considered having overlapping prescriptions for opioids and benzodiazepines. And again, those have come down both in Lancaster and in Pennsylvania over the past 4 years. One of the other things that's important to think about is getting people into treatment that need it. So we have some data from Medicaid patients about how many people have a known opioid use disorder or an other alcohol and drug disorder and have gotten treatment or not for it. So this chart shows patients who are in need of alcohol or drug treatment. So they have something in their medical record that they have a known substance use disorder. And then they look for whether those people have gotten treatment or not. And the darker colors on this map of Lancaster County show lower percentages of people who've gotten treatment. So greater need in darker regions. So you can see that the northern part of the county, somewhere around 40 to 50% of people have gotten treatment and the rest have not. And on some parts of the metro area, eastern, southern parts of the county, it goes up to more like 65%. So there's still a lot of people who are in need of treatment, but you can tell a little bit from this map about where some of the areas of higher need might be. And this map is similar. This shows patients with known opioid use disorder who are using medication-assisted treatment. And again, darker colors represent areas of greater need, lighter colors represent less need, more people in treatment. So over you can see towards the west, on the border with York County, we have the highest percentages of people who are in treatment using medication-assisted treatment. And again, kind of the north, eastern side of the county might be where there is a higher need. And this is the last slide that I have. This is about medication-assisted treatment again. So we can look at the rate of dispensation. So how much buprenorphine are we getting out into the population based on the size of our population? This comes from the Pennsylvania Drug Monitoring Program, or the PDMP. And on this chart, I put Lancaster along with some of our surrounding counties for reference. Lancaster, again, is the light pink line. For most of this chart, we are the lowest on the chart, meaning that we have the lowest rate of people getting buprenorphine. Although towards the end, you can see that there was a noticeable increase at the end of 2020 and the beginning of 2021. So that could be a really positive sign for people getting connected with MAT. And that is the end of the slide. So that's the end of the data update.
Hey, good morning, everybody. If you have any questions, please do put them in the chat. While you're doing that, I'll take a moment to introduce myself. For those who do not know me, my name is Chris Glover. I'm the project coordinator of Joining Forces for Children, and I will be your facilitator this morning. We do have one question about the data. Are there specific factors that differentiate the eastern and western parts of the county, rural versus urban population size? It is a great question. I don't know that I have the immediate answer to that question. Any of our panelists have any insight into that? We may need to get back to you on that one. There's the tricky part about, Brenda pre-recording her data presentation is it does make any follow-up questions a little bit trickier to answer because she might have some of that information at her fingertips. So she will be back in the office early next week, and we can certainly follow up on that conversation.
Chris,
Chris,
this is Alice. Can you hear me?
I can.
Okay. Yeah. Hi, everyone. This is Alice Yoder. So I'm looking at the question, and so I guess the kind of a follow-up question. I don't know that it's necessarily a data question. So in terms of, are there specific factors that differentiate the eastern and western? I think in terms of the data, I would venture to say that Brenda and the data is presented based on population size and rate, typically, when it's ever available. So from a data standpoint, I think what we see is what it is. That's my number one point, if that makes any sense. It's so hard to do this on and not in person. But and then the other part of this, then, if the person that wrote this question is asking the question, well, population size, so typically we allow for that when we present data. So if it's a pure data question, my guess would be yes, but again, we can come back with the specific detail after this meeting and send that out to everybody. But if it's meant more in terms of just sort of Eastern, Western, that's again one of those questions that as we have the panel and people bring in questions that we can sort of think about based on all the data, are we seeing any patterns or trends in different parts of the county that we would want to have a discussion about, and that would lead to an intervention as joining forces that we need to think about differently. So I think in terms of as we move forward with today's forum, you know, what we're mostly interested in, for those of you that have been at forums when we've been in person, is that everybody on this call has such rich information and comes from a different perspective, that coming together and joining forces, that we can come up with something that we do differently because we're meeting together. So, you know, I think it may look like looking at it from a data standpoint, we can get back to them, Chris, as you said, specifically, but my guess is that Brenda always takes that into consideration. It's all relative based on population size and all of that. So we really look to present the data from that perspective. But otherwise, it'd be great for people to put their thinking caps on, and as the panel presents and we get into Q&A, start really loading the chat up with some thoughts about what it is we need to do next. Because towards the end of this forum this morning, that's basically how we're going to summarize things. Okay, what's our next step? What do we need to do different? What do we need to do more of as a group that comes together and joins forces to address reducing deaths from opioids and heroin?
Alice, I do want to.
Go ahead, Sandra.
Sorry. Good morning. I do want to add to that beyond the information you shared, it also depends on the drug use, the substance that is being used from east and west of the county. So those also can be factors in regards to that in the data.
Yeah.
We
have a follow-up to the question asking more about the social determinants of health and what may be causing the east versus west difference. It is certainly something to look at, and I do not have that information at my fingertips this morning. I don't know if any of us do, but it is certainly a good point looking at some of those other risk factors. Carrie Lapp reminded me in the chat that in the Gap area, the Naaman Center has closed, and so certainly that could be another factor contributing to some of this information that we're looking at this morning.
And we do know from a poverty standpoint, social determinants, I think a lot of people on this call probably know this already, but, you know, we have in terms of municipalities, townships, cities, you know, the highest percentage of poverty is located in Lancaster City, second Columbia, and then Pequea Valley area and Solanco area, which would be the eastern and the southern part of the county. Between them and sometimes flipping up towards the Ephrata area, comes in, you know, third and fourth in terms of, at least from a social determinant, one being poverty. You know, that one we know for sure. But in terms of differentiating the eastern rural part of the county and the southern, it's really slim in terms of those numbers. But we could certainly look at other social determinants such as food, insecurity, and housing.
Mm-hmm. Mm-hmm. Yeah, great. And Gail is kind of not a question for an immediate answer, but putting in the chat that she would like to see data on trends in methadone treatment in our county and compared to the state and other counties, and then connected also looking at the local rates of HIV and hepatitis C prevalence trends. So Gail, I like that suggestion, and I will share that with Brenda, and maybe we can work towards that. I know that at least one of our friends from ARS is on the call this morning, and so we can connect with them to determine how we can do that. Alyssa shares, with transportation as a barrier, it is difficult for people in the Gap rural areas to find a way to treatment. Certainly transportation is a common barrier that we hear about regularly. That's a great point, Alyssa. Thank you for sharing that. Okay, I would continue to invite folks to share thoughts or questions with us in the chat. We have some great things to follow up on. We will be synthesizing I'm using the royal we, by the way. We'll be synthesizing all of this information and any questions that come in that we're not able to immediately answer today, and being sure to follow up with everybody who is able to join us this morning and folks who were not able to join us this morning to kind of keep the conversation going. So please know that we will, the royal we will be working on that. Thank you, Jess. We appreciate you and Elena helping to provide that information about local methadone treatment, and we will be connecting in the near future, I think. Okay. Fantastic. All right. So this morning, as we've kind of hinted to, and as you can see, we have a small group of panelists to join us this morning for a discussion. And so without further ado, I'm going to give each of our panelists a few minutes to introduce themselves, tell you a little bit about where they're from and what they do. And I'm going to borrow a lesson from anybody that has an opportunity to spend time down at the southern end, from my friend Joe B down there in Solanco. And if it feels like folks are going a little bit too long, I'm going to tell them that their coffee is getting cold this morning, so that we can make sure that we have some time to hear from all of our panelists today. So, without further ado, I would like to ask Dr. Mitch Crawford to briefly introduce himself. Mitch.
Hi, everyone. Thanks so much. It's a pleasure to be here. I love the great dialogue already in the questions, or in the chat, so please keep it coming. I will quickly introduce myself. I'm the Director of Addiction Services at WellSpan, and I am a psychiatrist by training. I specialize in the treatment of addiction, and I also serve as the medical director for a new clinic in York called the Specialized Treatment and Recovery Team. And I want to share with you just briefly about things I think would be pertinent to this audience. Two things. One is the warm line, and the other is our recovery support department. So the warm line is available for everyone at any time by dialing 1-844-WARM-LINE, WARMLINE. And it is for whatever you could use it for. It was originally developed for support for folks who are affected by addiction peripherally. So maybe you yourself are not struggling with a substance use disorder, but you have a friend or a loved one who is, and so you would have this opportunity to call and talk with folks as a confidential resource. You can remain anonymous. If there are treatment needs identified in yourself, it can be a referral to treatment as well. So please share that or use it yourself. And then also just sharing awareness of our recovery support department, who works in concert with all the other programs in the region, making connections to treatment, helping to navigate what admittedly can be a complex, dynamic treatment area for folks to navigate, and admittedly during some of the most challenging times of their lives. So we have that service to try to help people along. So I'll pass the mic so my coffee does not get cold. Thank you, Chris.
Excellent. I love it. I'm glad that resonates with you. Our next panelist that I would like to welcome is Scott Theurer, who is a certified recovery specialist. Scott.
Thanks, Chris. Hi, everyone. My name is Scott. I am the Director of Recovery Environments for R3 Recovery House and Recovery Support Services in Lancaster. I'm a man in long-term recovery. On October 4th, I will have 11 years of sustained recovery. And first came into the field as a person with experience as a client and a patient, knowing that things had to get better. And that's how I ended up doing what I'm doing today. But my experience led me to become a CRS, which is a certification for people in recovery, provides them education with some critical points such as confidentiality and ethics, and how to handle different situations with people that struggle with recovery or addiction. CRSs can and should occupy a variety of different places in our service system, in our recovery support system, in our treatment system. They can do everything from case management to peer support to outreach to warm handoff, overdose response. They can work in doctor's offices. In the last 5 years, we've seen a tremendous surge of that taking place, which is, I think, dramatically improving our understanding of the illness and of recovery. My volunteer role is with the Lancaster County Recovery Alliance, and what we do there is we try to promote recovery and the role that it has in a healthy community within Lancaster County. We were talking earlier a little bit about some of the shadings on Brenda's map in terms of treatment participation. I think some of that, I don't have data on this, but I think some of that has a lot to do with information and education, attitudes and perceptions, because it varies wildly as you go around the county. And I think you'll find that that does affect people's acceptance of treatment and also the access. So I think that's something that we could think about moving forward. And then last but not least, what I do at R3 is I am the Director of Recovery Environments. My job is to make sure that we serve about 100 men and women in Lancaster. A recovery residence setting. We offer social services, peer support as part of what we do. Our goal is to help people recover with dignity and respect, provide as many resources and access to those resources as we can. And my job is to make sure that the managers, people that work with our residents, have the most up-to-date training and education, and that we are providing services in a way that promotes accountability, but also that promotes recovery-oriented proven practice. So it's really exciting what we're doing at R3. It's really, to my knowledge, the first recovery residence recovery program around here that's doing what we're doing. So we're sort of learning as we go, but it's really an exciting process. That's all I got, Chris. Thanks for the invite to be here.
That's perfect, Scott. Thank you. And I do think that, understanding the attitudes and beliefs and how they impact kind of the readiness and acceptance for treatment is a valid point. And I will just take a quick moment to let folks on this call know that the Lancaster Joining Forces Steering Committee has been exploring for a while the opportunity to conduct a community-based survey to understand those attitudes and beliefs. And so just recently we were able to secure some funding, thank you Retreat Behavioral Health, to make that possible. So that survey will be conducted very soon, and we will have those results available towards the end of this calendar year and be able to share that with everybody. That will be another component of the conversation that will help us better understand some of these things. So thanks for that teaser in a way, Scott. Okay, next up, I would like to welcome District Attorney Heather Adams.
Good morning, everyone. As Chris said, my name is Heather Adams. I'm the District Attorney of Lancaster County, and I'd like to take my time here this morning to share with you the efforts that my office is undertaking to address the opioid crisis. So, as you may know, the District Attorney's Office is responsible for the prosecution of criminal cases on behalf of the citizens of Lancaster County. And we're also responsible for the protection and the safety of the citizens of Lancaster County. And that goal or that mission of public safety is really our core function. So how do we achieve public safety when we're dealing with the opioid crisis? I'm going to briefly talk to you about two things this morning. First, the Drug Task Force and its role in addressing the crisis, and then the role of diversion programs and what impact they can have on increasing public safety. So addressing this crisis from a law enforcement perspective has really been a top priority in my administration. The Lancaster County Drug Task Force is the agency that's leading that charge, and the Drug Task Force falls under the complete operational control of the District Attorney's Office. So the Drug Task Force, or DTF as we refer to them, consists of county detectives, municipal officers, and they work with both our state and federal partners to reduce the supply of opioids coming into the county, one, to prevent addiction, and two, obviously, to hold drug dealers accountable for those crimes. So since 2020, when I took office, the Lancaster County Drug Task Force has arrested over 100 dealers. They have taken 194 grams of heroin off the streets. That equals about 6,476 dosage units. They've taken 174 grams of fentanyl off the streets. That equals approximately 5,794 dosage units. And with the assistance of our municipal police departments throughout Lancaster County and the National Guard, they have destroyed over 8,076 pounds of unused medications. So those statistics are quite significant, and I'm proud to be a part of that. I can tell you, though, that the drug crimes themselves, such as possession and delivery, account for roughly 17% of crime committed here in Lancaster County. But we all know that there are so many other crimes that are the direct result of either someone being under the influence or someone seeking to support the addiction that they have. So when it comes to addressing a portion of these crimes, especially ones that are nonviolent in nature, my administration will continue to support the diversionary programs which are aimed towards rehabilitating an offender and addressing the underlying root of the crimes that are committed. So prosecuting cases is more than just locking people up. And here in Lancaster, we have 3 treatment courts, meaning they are treatment-based. They are team-based approach. They are treatment-based, which allows offenders who graduate to receive either a reduction or a dismissal of their charges. We have an accelerated rehabilitative disposition program known as ARD for both DUI and non-DUI offenses. We also have a diversionary program available at the magisterial district justice level for those who are suffering from substance abuse issues. And we have a pre-arrest diversion program that we support, which is Second Chances, which allows officers to use discretion to offer an offender either the choice to enter the criminal justice system or to seek treatment. So these programs are really important to me because I think that sometimes it can actually be the criminal justice system that serves as an incentive for someone to get the help that they need and to essentially give them a second chance. It allows them to seek the treatment they need, the services they may need. It may better the community by requiring them to complete community service. A victim may be made whole by requiring the offender to pay restitution, and it allows them to avoid a conviction. So by addressing these underlying issues that cause crime, we can reduce recidivism, and therefore we increase public safety. So to finalize, I just also want to mention that I'm very grateful to participate with the Joining Forces mission. I look forward to these meetings, and I can just tell you that the experience of the people that participate in these meetings and the way they approach it, they truly care about this crisis. And I just want to thank everyone involved for allowing me to participate. Thank you, Chris.
Thank you, DA Adams. We appreciate your participation and collaboration. It certainly is a complex issue, and your participation helps us better understand the complexities. So thank you. Okay, next up, I would like to welcome Darrell Fisher. Darrell.
Well, good morning. First of all, thank you for the invitation to be on this morning. I appreciate that, and my name is Darrell Fisher, like you mentioned. My role here at New Holland EMS is as EMS chief, and so that's my full-time job. But as a volunteer role, I serve as the president of the EMS Council, Lancaster County EMS Council. And so as daunting as it is, I kind of step in as maybe more of a liaison as all the EMS agencies come together and try to work together through the pandemic, through issues that we talked about this morning. Some of my background, I spent majority of my time here in Lancaster County, but I worked in rural areas like Perry County. I spent time on the streets of Lancaster City, and now pretty much work here in New Holland, where our territory, butts up against Lancaster City all the way down to Chester County. So we have a broad, scope. But it is refreshing for someone that's been on the street to hear a panel like this working behind the scenes tirelessly to combat what we're speaking of this morning. I know as boots on the ground, it can get tiring. You know, we pick up individuals off the street that don't have health, don't have transportation, and you know it's easy to explain that the system's broken. But quite refreshing to hear, you know, a panel like this working very hard to combat that. I would say, you know, the last year things have changed drastically for our personnel, and one of the biggest things that we're talking about now is just the mental health of our providers. So within 12 months, we've probably dealt with more mental health than I have in probably 20 years. Some of that is certainly the pandemic and what, you know, COVID has brought to our team, but more importantly, probably the emotional health of our patients, and that's just wearing down on our providers. So I appreciate being here, and I love the opportunity to answer questions and have dialogue with a panel like this.
Great, thank you, and excellent foreshadowing, Darrell. We are gonna talk a little bit more about the toll that the past 18 months or so have taken on professionals and community members. So thanks for teeing that up for us. And last but certainly not least, Sandra Valdez from SACA. Good morning, Sandra.
Good morning, Chris, and thank you also for allowing me to be here today and be able to present in regards to the services that SACA offered to community for over 45 years. Many individuals do not know that our services that exist in our organization are predominantly for Latino population, but we have actually branched out to everyone in the city and county who may need services beyond the Latino population. As the Chief Operating Officer at SACA, I try my best to assist our team and our community and assess what are their needs. And throughout the year, SACA has increased their services and expanded their services to be able to provide some wraparound services when it comes to drug and alcohol, substance abuse and use. And as you know, Chris, we have an inpatient drug and alcohol program for male 18 and older, as well as we have the step down program for the halfway house. And of course, we also have a recovery house for those individuals once they complete their inpatient and their recovery program, as well as our outpatient services. And the reason why I mention this is because we understand that individuals who are in recovery do need additional support before they're actually integrated back into our community. And SACA has its mission to be able to foster that among all of the clients that we serve in our program, and ensure that once they end up in, for example, in our recovery house, which is a 8-bed house, or for individuals who really are trying to get away from the people, places, and things, trying to maintain themselves sober and be able to reintegrate themselves into the community. And we provide that opportunity for them to be able to stay there up to a whole entire year, and then to provide them that support that they need to continue to sustain in recovery. In addition to that, with our workforce development program, we kind of help these individuals, and we understand that as an organization, we need to give these individuals the opportunity to be able to be integrated back in the community. So there are different factors and determinants that can lead the person to relapse. But if we provide them the opportunities, such as an employment, education, volunteerism in our community, and be accepted as any other individual, then the individuals are more likely to maintain sober and in recovery. So I'm pleased to be here today and hope that I can provide additional assistance and really exhort to the audience that if you have the opportunity to be able to open your doors to provide volunteerism for individuals in recovery, or opportunity for training for them and their family, this is a great opportunity to be able to help them and know that they can unite back into society as anyone else, regardless of where they're coming from. So thank you again, Chris, and look forward to the questions in the chat.
Thanks, Sandra. Yeah, I think one of the things that I've learned about our local recovery community is they're incredibly committed to giving back, and that is an asset for all of us. It's protective factors for all of us, and so anytime that we can promote or encourage that, I think that's fantastic. So at this time, we're going to ask our panelists some questions, and so we invite you to put any questions that you might have for our panelists in the chat. but I have one to get us started. So, DA Adams, this is going to come your way. We've long understood in the drug and alcohol field that increased access to substances often leads to more substance use. So I'm wondering, from a law enforcement perspective, and what you're understanding from, the boots on the ground and the drug task force, what is availability of substance in Lancaster like, and what are the substances that are most accessible locally?
So, I can tell you, unfortunately, we're seeing all the substances. Marijuana has not gone away. We're seeing it in different forms, probably now more than ever, such as butter and wax and oil. Fentanyl, there's been an increase in the seizure of fentanyl over the years. And in fact, the Drug Task Force will share with me that most people are searching and seeking out fentanyl now as compared to heroin. We're still seizing heroin. We're still seizing cocaine, both in crack and powder form. And methamphetamine is also making a huge jump recently in the past year or two. That's probably trending nationwide as well. And we're specifically looking now for methamphetamines or other amphetamines that may be laced with fentanyl. We think that may be the next trend that we see here in Lancaster County. I would say of all of those, fentanyl is the issue for us right now. When it comes to just the overall availability of substances in Lancaster and why that is, many of you may have heard about the 222 corridor and the fact that we have Route 30 and we have the turnpike running through Lancaster County. And there is truth to the fact that, when you have major, highways like that substances are easily transported into the county. But we certainly can't, avoid the kind of the common sense principles of supply and demand. So, if there's a demand for these products, they're going to find their way into the county.
Okay, thank you, DA Adams. So, understanding that the fentanyl is much more potent, Dr. Crawford or maybe Darrell, what are your thoughts about that contributing to the increase in fatal overdoses in Lancaster County in 2020?
Thanks for the question, Chris, and thanks for your comments, DA Adams. I think that it's an undeniable correlation. Of course, when we think at a national scale about the opioid epidemic as a whole, we think about the timeline in waves. And then so there, in the beginning, there was the kind of prescription-fueled epidemic leading towards folks, another wave using illicit opioids. And it was, at that time, a lot of heroin that was cut. And then there was pure heroin. And then now, the infiltration of fentanyl and other synthetic analogs, like other things such as sufentanil and acrofentanil, which you may have heard about, that are even more potent than fentanyl itself. And so it really is a scary time because, as DA Adams was wisely commenting too, that folks are using fentanyl sometimes even unknowingly. Right? So they think that they're having some product that is not an opioid, but is either contaminated or intentionally mixed. So we're seeing products like Scramble, which is not new to the region, but is seeing an increase in use. The DEA actually yesterday sent out an email about fraudulent prescriptions that folks are buying online, that the pills that are coming are actually not at all what is being advertised and are actually often containing fentanyl and other substances. And we're even seeing, in my opinion, a scarier trend where in Berks County, if anyone's familiar with this, they saw within a week something like 71 overdoses that just completely overflowed their system in inability to respond and treat medically. And the compound that was identified is unknown. And so we're thinking some novel synthetic opioid that we don't really know about is presenting differently for folks who survive the overdose are experiencing altered mental status sometimes for up to a few days, and some other complications such as severely high blood pressure. And so that's kind of the concerning trend. And it's not unique to the opioid market either, right? So D. Adams was talking about the different products that are available for cannabis or marijuana. You're seeing synthetic cannabinoids and such that are leading more towards being more pro-psychotic, or having folks having more delusions and hallucinations, and sometimes that never goes away. So I could go on a soapbox for that for a long time. If folks are interested, please put questions in the chat. But yeah, in my opinion, it's an undeniable correlation, and it's very, very concerning. And I think we need to acknowledge that, and also be looking into the future with a preventative lens of what's next, because the industry and the market is certainly not standing still.
Yeah, yeah. Darrell, do you want to add anything to that from an EMS response?
I will just briefly, and Dr. Crawford had probably a much nicer way of saying exactly what was on my mind. So I would agree. I think the reason we're seeing Narcan administration go down for EMS is simply because we're trained to use that as an airway tool. And so we come in, and even though we know it's possibly a heroin overdose, if the patient's breathing in a way that we don't have to address the breathing, we don't just administer Narcan to wake them up. So we're protecting their airway, and we're doing our assessment. So we've seen that shift very drastically, where we're not seeing, the hibernated state of these patients where we need to come in and correct that with Narcan. We're seeing almost exactly what Dr. Crawford said of everything in between, psychotic, just the increased temperature, violent, where families are, they know they've taken something new, they have no idea what, but we're faced with something we have no idea what's in them. And so we're trying to keep them safe medically and also physically, and try to get them to a doctor. So we've seen that change, drastically. And it's hard to put, on the street, we have no idea what they've taken. But certainly we're not seeing, the sleepy, hibernated, barely breathing. We can, administer Narcan and fix that. We're seeing, the opposite of that.
Okay, thank you, Darrell. Definitely a very complicated polysubstance use situation. Scott, there's a question for you in the chat from Gail asking, how many recovery homes do we have in Lancaster County to your knowledge? And how many people roughly are in recovery housing?
Well, there's 40 something, I think 40 listed on the CAB site as recognized recovery houses. They're the ones that are eligible for the scholarship from CABHC. They meet frankly, minimum standards, but and I would say there's probably about 5 or 10 more, so maybe 50-ish, and probably anywhere 500, 600, 700 residents and people per house. So that's roundabout.
I think that's a fair estimate. Sandra, would you agree?
I do agree with Scott's numbers in regards to the recovery. And that's also definitely needed in the community, as they continue to step down and complete their programs in inpatient and outpatient, having a recovery house in another location where they can provide additional support in that area, especially if they're coming from outside of the state or from other counties that they're not familiar with, that would be very helpful in maintaining them sober.
Great, thank you. So, Dr. Crawford, I have another question for you about medication for addiction treatment. And Brenda, in her presentation, showed us a chart where, over a period of time until recently, the dispensation rates in Lancaster County were lower. And just wondering if you have any insight as to why that may have been the case, and what this recent shift may be, despite the number of waivered providers that we have in Lancaster County.
Of course, thanks, Chris. You know, in the steering committee meetings, we've shared dialogue about this. It's a really good and important question. I wish I had like the answer for you. I can certainly share some of my thoughts, but if I had the answer, we wouldn't have the problem that we're seeing. I think some of it is what we were talking about earlier. So there's some great comments. I forget who was asking about methadone treatment. So I don't know those numbers for Lancaster County, the amount of folks who are in treatment with methadone. Maybe it's a higher proportion than neighboring counties or other counties in Pennsylvania, for example. And so there's less people then who are needing or utilizing buprenorphine as an outpatient. That's a possible explanation. I don't know, though. I can tell you there is a difference, and someone wisely asked this question earlier, in the substances that are used, right? And so depending on where you're at in the state or in the country, you see huge trends. You know, in the Midwest, for example, you're seeing kind of a flip-flop where folks are more widely using stimulants such as methamphetamine and rarely using opioids. Their trend is kind of merging, just like our trend is merging, where we're the opposite, you know, of high use of opioids and smaller use of stimulants changing. But that's true at the county level too. So someone wisely pointed that out earlier. You know, what folks are seeing on the eastern side of the county is a little bit different than what we're seeing on the western side of the county. I'd also, you know, I'm not going to name names because I would leave folks out and I would feel terrible about it, but the distribution of treaters and treatment site availability is very different depending on where you're at in the county. But I think there's some of that. And then I think there's just the realization that addiction treatment where we're at today is relatively new. Right, and it's a bit of a younger field, and expansion of, you know, the hub and spoke model in Lancaster County, for example, is newer, and so there's a lag, you know, of culture change and stigma, which is another thing that we're going to be learning more about with joining forces. I don't know if someone will be talking about that, but yeah, I think there's, you know, if you build it, they will come. So it's being built out, and then now it's an opportunity to kind of spread through the community what's available. I think one thing that's important is to, and you pointed this out, Chris, to make a differentiation between folks who hold the waiver, the Data 2000 waiver, as we colloquially will call it, the X waiver. Now there's the notice of intent, if folks are familiar, that the X waiver now has a waiver to not need the waiver. But just because you can prescribe it doesn't mean you are prescribing it, right? So it is not unusual for a health system to have, I'll just use easy numbers, 100 people who have an X waiver and only 20 of them are using it. So I think there is, you know, we have this huge push to get as many folks trained as possible. And then the next push is, okay, how do we actually get you to use it now? And I think, and I know that health systems all throughout the region are all working on that goal. So those are my thoughts. I'd love to hear thoughts from the group as well in the chat.
Great. Thank you, Dr. Crawford. I agree. Hearing some more perspective would certainly be helpful. And to that end, I'll ask Sandra if you have any other insight to add about kind of that disproportionality there.
Yeah, thank you, Dr. Crawford. I would also add to, you know, access. I know we've been discussing or sharing about access in the community, depending on in the areas is where providers are and able to meet our clients where they are at. Another thought that I would say and that we've come across is also it depends on the health insurance coverage that the individuals may have, or if they're uninsured, then it makes it a little difficult because they don't have necessarily the income to be able to support for the MAP treatment program, even though we are providing free care to the patients, and then also it also follows up with all the follow-up that that person needs to comply with, and some individuals may not comply fully, and even though they're utilizing the MAP program, unless they're utilizing the injectable portion of it, then, we do come across with individuals still, coming to the program and not trying to comply with all the regulations that come with being in the program. So we definitely stress the education and the awareness that these programs do exist and be able to provide that access to and from.
Great, thank you. I've heard education a few times this morning. There may be something to that. There is another question in the chat for Scott and Sandra. Do you know what percentage of recovery homes allow or support residents who are using medications for addiction treatment?
Probably not enough. Go ahead, Sandra.
Go ahead, Scott.
I would say not enough, but again, going back to education, it's going to be a big theme because I've been working in the industry. Very clear to me that there is a lower bar set for education in terms of MATs. Some houses allow buprenorphine, but absolutely no methadone. And they have reasons for it, and I get the reasons, but we have a lot of work to do. More and more have opened to medications. I mean, 5 years ago, it was a radically different scene. People just said no. We didn't want to mess with it. I don't have a percentage. I can just say it's getting better, but we really need to raise the bar on the education and the amount of support that we are able to give these houses and that work in these houses to support people who are on MATs. A lot of the folks that are on these medications also do not have the education that they need, and they don't have the support. So we're making efforts, we're making strides, but we have a lot of work to do.
Yeah, I
Sandra?
think that's that. Most definitely the support. If we kind of understand the difference between a halfway house and a recovery house, even though there are some type of individuals in the medical field assisting the individuals in recovery, they're not always run by 24-hour day professionals in those particular locations. So there are some recovery houses that do allow and permit the patients or the clients to be in any MAT treatment program while there, and they are very selective into what those medications are or treatment that they can receive. But I definitely believe the support is most important, being able to have that additional support while they're in that treatment and program, and determining when it's the great time to step down because that person's ready to be back into kind of integrated into the community. So it's pretty much a community effort, and if we're all at the table and supporting our clients and patients, then we're better likely to help them move forward.
Right on. I'm all about the community effort. Scott, you sort of alluded to some issues around why recovery houses might be reluctant to admit residents on MAT. And we have a question in the chat kind of asking for some of those barriers. Can you speak a little bit more to that?
Well, it's sort of, number one, it's being afraid of things you don't understand. And then number two, sometimes it is prescribing practices and individuals' lack of adherence to prescription. So, you might have somebody that's on Suboxone and other medications that's having a reaction to that medication. They try to manage it themselves instead of doing what? Going back to the doctor and talking to the doctor. A lot of behavioral things that are involved in recovery. We have to learn how to do things the right way. And if you have somebody that looks under the influence in a community setting, it's very disturbing to the other residents, and it can be triggering. And so the ownership's response to stuff like that is to just say, we're not messing with medications, period. Because we are not a clinical setting, we're a residential setting. Most houses are not equipped with the right kind of training to be able to navigate through situations like that. And they really shouldn't without that training, because they can really cause damage. So it's a touchy situation. And again, we're working on it. We're trying to look at ways we can improve, but a lot of it comes from, again, education.
Mm-hmm.
Can I piggyback on that, Chris?
Please.
I apologize for hopping in, but I just want to empower everyone on this call, because we have a lot of really smart, dedicated people who are here because they care. I see 54 participants, and so that's 53 more voices, right, than mine. And I want to just share with you, If you hear anyone say something like Scott's talking about, kind of being afraid of what we don't understand, if you hear some of these three, what I call myths, I encourage you to please respectfully and professionally challenge them. And if they want more information, you can always point them in our direction at Joining Forces. And one is that medication-assisted treatment is a substitution of one addiction for another. It's not, and I could talk for an hour about that, and I won't because I just hopped in here. Another one is that, well, folks just divert it and sell it anyway. And we can talk about, diversion rates, and yes, some medication is diverted. But if you really look at where it's being diverted to, it's being diverted to folks, or the majority of it is being diverted to folks who don't have access to treatment. And so that is a problem with our access to treatment. And the third one is that it doesn't work, or that, it's not effective. And we do have studies that show medication-assisted treatment is just as effective as treatment for other chronic medical diseases like substance use disorders. So I empower you, I encourage you, please respectfully challenge folks who make those comments and point them in our direction if you need some backup.
Thanks, Dr. Crawford. All excellent points and things that, even though I believe we've made some headway, we do still hear some of those myths in the community. We have a question coming your way, Dr. Crawford. Are you finding any issues with the effectiveness of MAT for opioid use disorder using fentanyl?
I will answer this quickly because I've been talking too much and I don't want my coffee to get cold, Chris. So it's a complicated answer. It's a yes and a no. So effectiveness, I would say not really effectiveness, but the induction process, or when we start people on the medication, has been more challenging. There's a lot of reasons for that, and we're learning more and more about it. And this past year, our national meetings for the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry, we spent a lot of time talking about this and what's the best way to start folks on the medication, because if you've heard of precipitated withdrawal, which is essentially if you start the medication too early, you can make folks really sick. And it's it's a trickier situation when folks were using fentanyl, and specifically when they were using large amounts of fentanyl for multiple days in a row, months in a row, years in a row. So that's how I would answer that quickly, is it's harder to get people started in a more comfortable way, but the medication seems to be effective still.
Great, thank you. Anybody who wants to dig into that further, do let us know. I will share, as Rose is reminding us in the chat, that the South Central Opioid Awareness Coalition, which is sort of the medical arm of Lancaster Joining Forces, is meeting regularly, and they are discussing these issues, and that is across all of the local health system providers. So I think they're digging in to understand some of those complexities as well. Darrell, I'd like to follow up with you on something that you alluded to earlier in terms of the EMS workforce being kind of on the front lines of these two co-occurring crises, COVID-19 and the ongoing overdose epidemic, and just wondering if you can elaborate a little bit more on some of those challenges and maybe some of the things that you're doing for your workforce and any opportunities for this group to kind of support those efforts.
Yeah, absolutely, and I appreciate that opportunity. So let me just for a minute selfishly talk about our EMS professionals in the county. And so it is my job, so I view myself as one of the career EMS folks. However, majority of the county and the calls that are being handled have volunteers on them. And so you have two very different kind of ends of the spectrum coming together and providing care for the community. And it's easy for them to say, the system's broken. And when I see a panel like this and the help that's out there, sometimes it's a good reminder, and I need to go back to our team and maybe remind them or refresh how much is being done behind the scenes. Our health systems are full. So currently, if I look at our CAD, multiple health systems, they're on psych divert, they're on ED divert, they're full, And so when we transport these patients, that I would love to take them to anyone here. There's a few folks that I would love to have on speed dial to transport them right to their office. We end up in the emergency departments that are full and have active dying patients of COVID, and maybe our patient just needs to talk to someone that evening. But our folks are seeing them not get the help they need. And so I don't want to throw the health systems under the bus, but I think it's a trickle down effect, and COVID probably overturned something that I haven't seen in the 20 years where our folks are being effective personally. So when we have volunteers that are in their hometown, in their communities, responding to their neighbors, it wears on them, and they come to my office like they don't see a way out anymore with some of these folks not getting the help that they need or should be getting. A lot of them aren't in the EMS for the lights and sirens. Those folks are usually gone in 3 or 4 months. The EMS is just not about the lights and sirens. So it's more about the personal relationships they build and really caring about that person in probably one of their worst days. They're calling 911 at some of their worst times. And so they want them to get help, and they spend 15, 30 minutes with them, hoping and trying to get them to agree to help. And then often within a day, we see them again, the same type of call. And that slowly has been wearing on all our folks. And like I said, within 12 months, we have providers that have only been on the street for a year or two, just walking out, and at a mental state that I've not seen our providers ever. And so a lot of them are concerned that maybe COVID has overshadowed some of the emotional needs of our patients, where we go to the health departments, they're worried about COVID, number one, but there's a lot of mental health issues that we feel are being ignored in the midst of COVID. It's going to be challenging, stepping away from this. A lot of our EMS agencies are very short-staffed, and then that just, again, trickle-down effect. But we have less ambulances and more calls, and so it's hitting our workforce like I've never seen it before. But probably more concerning for me is, back home here in my agency, is the mental health of our volunteers that are in their own communities trying to help their neighbors, and hard for them to see, through some of these issues that I just laid out.
Yeah, I don't have any words of wisdom. I wish I could wave a magic wand. It's been a very challenging year in a lot of ways, and I would suspect that it's hit your team a bit harder in some ways than it has those of us who are not, like you say, seeing folks on their worst days and carrying that with them throughout their days as well. Sounds like, folks, there's opportunities if anybody is looking to volunteer. It sounds like there are opportunities to do so, and if that's something that's interesting to you or someone that we would certainly love to help you get connected to learn more about how to do that. DA Adams, there's a comment in the chat about some facilities, including jails and nursing homes, that discriminate against people who are on a particular pharmacotherapy for opioid addiction, being prosecuted as an ADA violation in other states, as well as civil lawsuits. Just wondering if you have any insight to share on that at all at this time.
So I would think they are referring to more of a civil prosecution or even a civil lawsuit, something that the Attorney General's office has a civil bureau may be able to look into. I'm not really aware of that issue or any such lawsuits ongoing in Pennsylvania at this point. I could certainly take a look to see if anything like that has been initiated in Pennsylvania.
Okay.
I don't believe it would be a criminal prosecution, though.
Okay. Helpful clarification for me. Hopefully helpful for others. Appreciate it. Becky is asking, what evidence do we have that the diversion is to those that cannot get into treatment? I would think that the diversion happens so that those that are diverting have money to buy other drugs, and those that are buying it may not be willing to go into treatment. Give us more insight. Oh, that's actually Michelle, not Becky. So Dr. Crawford, I think that might be to you. You know, if you need me to repeat that.
So, of course, there's always, I don't want to use the term bad actors, but when we think about describing kind of legal situations, that was how we would describe them. So there's always going to be folks who are, diverting medication with the intent to sell and have money, or maybe they don't even have opioid use disorder, and they read online the things to say so that they can be prescribed. Everything we do in medicine is a risk-benefit analysis. And so, the majority and the vast majority, if you look at, large studies, whether they're doing retrospective surveys with folks who are now in long-term recovery, asking them, how many of you have used diverted buprenorphine? The vast majority of them say yes. And then they ask them the reasons why. And the majority, a more recent study is like 83% of them were using it for therapeutic reasons. And the largest reason why, when they asked that, was because they didn't have access. And if you look at, this is national data set, if you look at how many folks have access to treatment for a substance use disorder age 12 and older, there's still a huge gap where 89% of them do not have access to treatment. And so when you add all that up and you look at the risk of, there's going to be a small percentage of folks who are bad actors, and there is a much larger majority of folks who are using it appropriately. It's a risk-benefit analysis, that in medicine where I say the benefit outweighs the risk of me, if it's clinically indicated, prescribing this to someone, having a good faith effort, but that's not to say that we don't try our best to control diversion, right? So it is against policy from the DEA. You can lose your license, you can experience criminal charges if you knowingly continue to permit and prescribe to someone who's diverting. So if someone tells me that they're diverting their medication, or I'm, not doing urine drug screening, or I'm not doing pill counts, or I'm doing those things and it's showing me that, the buprenorphine is not in their urine and I'm prescribing these pills month after month to them, or tablets or whatever, that is not okay. But to say that we should withhold treatment of medication-assisted treatment to folks because there are some bad actors in the system is a point that I think has been refuted by the literature and what we see clinically.
Okay, great, thank you. And Michelle, that was your question. We can certainly compile some of those resources that Dr. Crawford referenced and share those if you'd like to review the literature personally.
Yeah, I appreciate that. And I appreciate the question too. I think, all the questions are great. I'm having trouble reading all of them in chat. I love how engaged this group is. But I encourage everyone to ask the questions, right? Like, if we're saying something that doesn't make sense, or you have a different thought or opinion, that's the point here. We want to share the dialogue.
Absolutely, absolutely. And Lori is asking about any research being done locally on drug use trends among school-age populations. And I see that Sachi has chimed in with exactly what I was going to offer, which is the PA Youth Survey that is administered every 2 years throughout the state of Pennsylvania. We have pretty good participation in Lancaster County. It's given to 6th, 8th, 10th, and 12th graders. And that is really sort of the best information that we have to understand locally the trends among our youth. Those results are available publicly through the PCCD website, and so we can certainly make those links and reports available, as well as all of this other fantastic information we're sharing today. So Lori, I know that you're working in the capacity of serving IU13 and supporting some private schools, and there are some private schools that participate in the Pennsylvania Youth Survey, and so it is currently being administered now. Not 100% sure, but I think if some of your private schools are not yet signed up to participate this year, that they may still have a small window of opportunity to do so if they're interested. And then those results from the surveys that are being conducted now will be available in the spring. It's usually late April or early May when those are available. So anybody have anything else to add on that? Sandra, I know that your group does some prevention work. Wondering if you have anything to add to that.
Yes, we do some prevention work. We implement the LST, the Life Skills Training Program in the school districts to allow us to come in from as young as third grade and up to the high school. I'm also board member of the CPA of Pennsylvania, who also is involved in the PA and the PAYE survey and being able to distribute them. So I would say that if there's anyone on the call who does not believe that their school district is not participating or not enough enforced in there, to also please contact the CPA and they will ensure that they communicate with one of those particular superintendents or principals in those schools.
Great, thanks, Sandra. And CPA is the Commonwealth Prevention Alliance, and they do at the state level kind of help to advocate for and coordinate, offer a lot of education for prevention professionals. So another good resource for folks. Scott, we have a question coming your way. Would you share more about your focus on the recovery environment? For example, would you share the type of education you are providing to help sustain recovery for the individual and for family?
Specifically, education is provided to the house managers. Everything from we're doing a big trauma-informed training coming up in October, which is really cool. I'm really excited about that. And then it's basically because so much of recovery is behavioral. You have to let go of old habits and replace them with good habits, and people have to learn that. So, folks that come into R3 right out of rehab are getting their head together. They're untangling things. They're dealing with learning about recovery, and it becomes really important that they see good positive role modeling. Everything from the language that we use, the way we treat one another. It needs to be positive. It needs to be health-based. We need to model and teach how to make good choices, how to process information, how to resist, sort of our unconscious abilities to be impulsive about what we do and how we live in an emotional state that can lead us into trouble. So it's all of that, and it's a peer-to-peer type of thing. So everybody needs to be on the same page, and the environment is really picture a fishbowl and the water that's in the fishbowl. Everybody contributes to that. We're all in it together. And so, my job becomes walking around and being able to connect people together and pass that message along and really encourage people in a positive way to try to sustain that environment. If that answers the question.
I was on mute. I hate it when that happens. Did you want to add anything about education for family members that may be ready to kind of welcome their loved one home?
Well, we do a lot of referring. I know DSAA has a pretty good family program running, and we do work a lot with private therapists or residents that have family members that are interested. We will pay for 3 initial sessions for people to reconnect with, or at least start the process of dealing with a lot of the damage and trauma that comes out of a person's addiction. So we don't specifically do family services within R3 itself, but we absolutely recognize and refer people to services to get that process moving.
Okay, Great. Yeah, it is. It is certainly an illness that impacts every person in the household, and so it is definitely, better outcomes for everybody when everybody in the household has the opportunity to get that education and start their own recovery process. And so, we at Joining Forces for Children are available to support young folks 0 to 18 through their own recovery process when they've been impacted by a loved one's substance use. Okay. Let me know if you want to know more about that. You can get in touch with me later. So I'd like to kind of in the last couple of minutes here we have with our panelists, I would like to toss one more question to you, Dr. Crawford. Darrell has alluded to it, and I think it's come up a little bit in the chat and through some of our other comments that, many people have reported experiencing more poor mental health days throughout the pandemic, and then we know that there was also increased substance use. And so as we head into the fall and the winter, which can often be, a difficult time for folks that have pre-existing, mental health conditions, what do you think? What are your projections or your predictions? What are you seeing or expecting to see? And then what sort of resources or recommendations would you have for folks?
Thanks, Chris. Great question. I think there's also another layer on there of where we're at in the pandemic, and yet another surge, yet more social restrictions, and yet more events being canceled, and trips being canceled, and all this adding up together is really hard, right? And so, we've talked in the past about why we think that there's an unfortunate increase of the overdoses and the impact and the sequelae of isolation, and how, this is so challenging with the pandemic where we're needing to isolate for safety, and at the same time, the consequences of sequelae of doing so. And as you're wisely stating, the weather changing, for former Game of Thrones fans, winter is coming. And it's real, right? And so I think one is, the question is perfect, just identifying the fact that this is happening, right? There's a congruency of all these things, and it's going to be hard, and it is hard, and we're tired. And so, we talk a lot about burnout. Depending on where you're at, I'm thinking about my colleague here, Darrell, how many folks and times he's making these trips and how hard it's getting. But I think also focusing on resiliency and what that means to you and how you can do it, because it's not really going to get easier. And I hate to say it that way, but I also want to just be real. We need to really figure out ways of how do we cope with this? How do we cope in a healthy way? How do we have recognition of our negative feelings? How do we allow ourselves to understand that it's okay to not be okay? How do we understand when it's okay to not be okay? And then when do we ask for help, and who do we ask for help from? And so, I always tell folks, try to be as kind as possible, assume positive intent in others. You're not the only person who's having a tough time right now. For me, my resilience factors are really important, are gratitude and taking care of myself physically. So I have this processing time. I like to run. It's time that I block out in my day, feel better. I'll process all those kind of thoughts that are ruminating. And my gratitude is really helpful. For me, my faith is very important to me. So I spend time in prayer, and I pray for things that I'm thankful for and that are blessings in my life. And I try to remember all the good that has happened in the day, because it's easy to get really focused on the bad things and then forget to spend time thinking about the good things. So there's a lot of ways to kind of foster resilience and to prepare yourself for challenging times. And if you want more information, you can reach out. I want to be respectful of time. The last thing I'll say is one of my colleagues, we gave a talk on this, talks about trying to be like Gumby and being flexible, right? So things are changing, and things are changing rapidly. And if you're too rigid, it's going to cause more stress. So if you can be a little bit like Gumby and be flexible, be kind, be caring to others, be curious, ask how other folks are doing. We may not be able to spend as much time in person with folks, but a Zoom call can go a long way. A friend you haven't talked to for a while, your grandmother, your son, whoever, reach out if you're thinking about them. You'll both feel better.
Absolutely. Absolutely. Thank you for that, Dr. Crawford. And so that is all the time that we have with our panelists today. We have a few other things that we'd like to share with you. So I'd like to give our panelists a round of applause and thank them again for starting their day with us and making this time to share their incredibly valuable insight. That I know that we did not get to all of the questions and comments in the chat. Please continue to put those in there. We will be sure that we follow up with you and get those questions answered and any other things that come up for you. So thank you again to our panelists. Okay, at this point, we're going to move along in our agenda and talk a little bit more. I'm going to piggyback off of some of the things that Dr. Crawford shared and talk a little bit more about the impact of these two epidemics that some folks are calling the twindemics. And so I think, for me, it's helpful to start to try to acknowledge, and we've heard it a lot over the past 18 months, but we have lived through something truly unprecedented. And we have all, whether we've taken the time to acknowledge it or not, we've all lived through some form of loss and grief. In my family alone, over these past 18 months, we've had our fair share of that. My partner had a pretty major heart attack, and we lost a loved one to addiction. We lost a beloved pet. We had other things happening in our lives just on day to day that were challenging, and were more challenging because of all of the things that we've lived through. All of us needing to physically distance to protect the health and well-being of our community. I saw family members and friends, really working harder than ever to maintain their recovery. It was challenging, but I think, like Dr. Crawford shared, reaching out to those folks, it was helpful for me, and I think very helpful for them as well, even though it wasn't exactly what either of us wanted or needed. It was what we were able to do, and it did kind of help in those moments or those days to get through that. And so I share all of that to just say that we've all experienced some form of grief and loss, and I'm sure many of you that are still with us today have similar stories, and that certainly doesn't include all of the social justice work that's been happening. We lived through an historic presidential election, and all of those things, big and small, that we've all encountered on a daily basis, or for some of us one moment at a time, that we've been trying to navigate. And so, for me personally, I don't know that I've taken the time to really stop and acknowledge that I've lived through this period of time that was challenging and traumatic. This is a historic, traumatic thing that I've lived through. And I think, kind of along the lines of what Dr. Crawford was saying, just acknowledging that can be helpful. And I think, many of us on this call today are in the helping profession, and we can certainly model that for the folks that we're trying to serve, just acknowledging that, hey, this is hard. We've experienced loss, and it hasn't been easy. But, we do know how to take care of ourselves, and so we can share how others can do that as well. Taking care of ourselves is really one of the ways that we can, foster some resilience. And so before I kind of talk to you more about how we take care of ourselves, I'd like us to just take a moment and really think about what are the things that are coming to our minds in terms of what it was like to live through this historic traumatic event. And so I would invite you to join me in this Poll Everywhere poll, either in your web browser by typing pollev.com/joiningforces. And this will automatically populate for you, and you'll be able to share just a word, something that resonates with you about what it was like kind of being a human being over the past 18 months. If you'd like, you also have the option to text in your response. And so on your cell phone, where you would typically type who you're sending that message to, you would type 22333, and then in the body of the text, you will type joining forces. Notice there is no space, so you're smashing those two words together. And then you'll send that text. You'll receive an automated text that lets you know that you're in the poll, and then you can submit your answer there. And so so we'd like to just take a moment and share collectively with you what has it been like living through this pandemic and the continued opioid crisis. Stressful, heavy, confusing, mind-numbing, challenging, heavy, confusing, yeah, uncertainty, all good words that resonate for me. I will wish that they resonate for many of you as well. And I did forget to say that, if Poll Everywhere is not your thing, you can certainly, of course, share any other thoughts you might have in the chat with us. Devastating. Yeah. Marathoning. I like that. It has definitely been a very long haul. Warming. Changing times, confusing, isolating. In my own sort of practice of gratitude, I've been very thankful for the technology that we do have. I have a young granddaughter, and the technology has been really the way that we've been able to stay connected, and that she knows who her Mamo and her GUI are. So, even though it does feel sometimes, lonely over the past 18 months, I am incredibly grateful that we have all this technology. We have texting, we have video chatting, we have, regular phone calls. I feel very, very grateful that I have those options to watch my granddaughter grow in this time. I'd like to thank you all for taking that moment to kind of share with us. I do hope that it's helpful to know that your colleagues and your peers are in a similar space as you are. I've had some conversations, particularly recently, about kind of just what a wild ride this past 18 months has been, and it's been helpful for me to kind of be a little bit more vulnerable and share a little bit more, and let folks know what I'm feeling and thinking, that they too are feeling those things, and that I am not alone in that. So you too, my friends, this morning, you are not alone in all of these thoughts and feelings that you are having as well. I'd like to share with you a resource that a couple of my colleagues and I have been working on in regards to self-care. And so we are calling this the Caring for the Caregivers Toolkit. And we have kind of developed a get started guide specifically geared towards professionals that are working in the helping field. And this is available on our website. I will put the link in the chat for you. And just automatically go to the webpage and you'll be able to download the Caregiver Toolkit. And we have it broken down into different sections. So just kind of sharing why we're making this toolkit, what is self-care, why is it important, what if I'm a supervisor or a manager, what if I'm leading an agency, what are some of the tools and resources I know, not just to take care of myself, but to support my team, my staff in that work so that they can be, you know, providing better quality services and supports to the people that we're serving. And then also family, right? Like we've spent a lot of time with our families over the past 18 months. And so, you know, if we're gonna journey on this endeavor, it can often be easier with family. And I would argue, being a family member of a loved one in recovery, that you know, this is an opportunity to better support any family members who are at any point of their recovery journey. And then we also have a section for what's kind of available locally. And then if you're more of a practice self-care on your own kind of person, we have some web-based options available there as well. So this is all available for you on our website. We also have started a YouTube playlist for folks who are looking for, you know, calming music or you know, guided imagery things, meditations, yoga practices, a variety of resources there for you on that YouTube playlist. And then we have other toolkits and tools available for you through Dropbox. And we'd also like this to be an ongoing resource that kind of is a living document. And we would invite you to share your favorite self-care practices or resources with us, and our team will be, you know, vetting all of those and will regularly be adding those things to, whether it be the YouTube playlist or the Dropbox or the web page. As you can see, we've got them divided up into different categories. And so we do hope that you find this valuable as a getting started sort of a guide. It would look forward to you sharing any other resources, practices with us. Well, okay, so that is our hot off the press resource to kind of help you launch practices. And so as we start to sort of close out from the morning today, we have a couple of questions, another way that we'd like to try and get a little bit more feedback about kind of understanding all of these challenges and where do we go from here, knowing that there is still a need for us to prevent and reduce the number of fatal overdoses. So why do you think, in addition to or you know, kind of reiterating some of the reasons why we mentioned throughout the panel, why do you think that Lancaster County specifically saw an increase in fatal overdoses in 2020? And again, through our Poll Everywhere poll, you can participate via the website, or you can send a text to 22333. And if you were already texted in participating, you don't have to start that again. But if you're joining us now, then you would text the 2233. So we have someone sharing that isolation was a contributing factor, availability, hopelessness. So Gail, I see your question about overdose fatality review. It is something that, you know, we are still exploring how to get a overdose fatality review team started. Part of that is a funding issue. Part of that is a being able to share data issue. But it is something that our team is still working on. Nothing, more to report at this time than that. But I do appreciate your question.
And Chris,
go ahead, Alice.
This is Alice. The only other thing I would add to that is that we are connected with the state in terms of the movement that's happening on the state level around opioid fatality review teams. And there is, some momentum on that end related to it. So as Chris said, we're continuing to explore what that might look like and how beneficial that would be. And anybody, interested in joining our team with getting regular updates in between these meetings, feel free to connect with us.
Okay, lots of great feedback on some of the changing risk factors that impacted overdoses in 2020. I'd like to invite you to participate in another question. So what are some of the existing strategies or services that we need to do more of? What are some things that might need to be scaled up or that there just might need to be more accessibility or availability of to prevent fatal overdoses? More counseling, more therapy. More Narcan in the community and more education about Narcan, education about medications for addiction treatment, education generally. For folks who are writing about education generally, if you have any sort of specific audiences to receive education or specific sort of content areas that we need to do education on, if you could include those in the chat, that'd be helpful for us to better understand what you're thinking about education. Legislation to promote support for access, more funding. Same with funding. Is do we need funding for something specific in particular? What would that be? More harm reduction, more access to Narcan, better transportation, more access to syringe service programs and harm reduction, busting the stigma, more emphasis on harm reduction, better support for it, homelessness resources. Could you be a little bit more specific about what you're thinking in terms of homelessness resources? What does that look like, do you think? Yeah, what specific type of legislation would we need? Would that be around harm reduction or overdose fatality review? I know that there may be a couple other things kind of in the works in that realm, but any specificity that you can give us would be helpful. Assistance to peer workers, recovery houses, group activities for the recovery community to do together, art, music, movies. Okay, great. If you can share a little bit more about assistance to peer workers and recovery houses, what is that? I'm not even sure what to ask to help clarify that. Permanent housing, low barrier access to housing, sobering centers. Follow through on collaboration. Okay. Okay. These are all good suggestions. And we have one final polling question for you today. What are the new strategies that can be implemented in Lancaster County that have not yet been implemented? And remember, we're looking for things that have been tested and effective, proven practices, evidence-based practices. What are those strategies that are not yet being implemented in Lancaster County that we could explore? Stabilization housing for people that relapse or experience overdose and do not access treatment. Training for family members. I'd ask the person who's talking about training for family members if you could share with us a little bit more specifics about specific content or anything like that. That'd be helpful. Mobile MAT services. Proven practice equals local public health department. Harm reduction, fentanyl testing strips. Overdose fatality review model. Somebody seconding the stabilization services. Appreciate that. Letting us know that you co-sign it. Full spectrum recovery services, housing, job placement, assistance, MAT, social and life skills, all in one place. Easier access to shift between levels of care. Too many barriers for patients to get into inpatient. Matrix recovery model. Okay. You've given us some great feedback, some things to think about and explore. It's clear that education is definitely something that folks feel would be helpful. And so again, I would welcome folks to share in the chat or to connect with us later. I will put my email address in the chat. I'd love to understand more about who needs the education and what specific type of education folks think would be most needed. Family having resources and support, and identify the use of family members and ability to walk them through the process. Okay. So it sounds like, lots more education and then exploring some things in terms of access to different levels of care and stabilization recovery supports are a lot of the things that I'm seeing multiple folks kind of share about. So as I have said, I think a couple of times, we will synthesize all of this, compile all of this. We may be following up with some of you to better understand some of this feedback and identify some next steps, but we will be sharing all of this. You can kind of keep an eye out for that in one of the Friday emails to come from Susan sometime in the next few weeks or so. Okay, well, I would like to thank everybody, and I'm going to turn it over to Alice, the co-chair with Commissioner Parsons of the Lancaster County Joining Forces, to just close us out this morning. Alice?
Yeah, thank you so much, Chris. And on behalf of everyone on this forum, I'd like to thank you for pulling it all together and making it seem like it's so smooth and easy as we go along. and particularly grateful for your talents of also making it very participatory. I still have a difficult time of us not meeting in person, so I'm not sure how everybody else feels, but when I see the names up here, I think of the times when we were together, and we probably hear ourselves saying that a whole lot, and how just that those connections physically being together. So the hope will be our spring forum, fingers crossed that the community is in a different position by the spring, and we will have our next forum in person. But until then, as Chris identified, we have some work to do on our end. So we will follow up with the data questions that you have, and also add some elements to our website. So really encourage you to, ping your calendar once a week, every other week, to check out the website with any updates, because based on conversations we have, we will be, as Chris already has the self-care toolkit up, but we'll be increasing the self-care resources as we see some here. And as you send more to us, we will continually update that. So keep coming back to that, and please share it. Everything's on there is for all of you to use. We'll put the myth-busting fact sheet up there too, the youth behavioral risk factor survey, some of those data elements we'll have on there too. I want to assure you that what I saw also was that there was an increased really interest in the opioid fatality review, which we know based on our last discussion, we think is really vital to make sure that we get new information to understand the situation here in Lancaster as much as we can, and we think that is the answer. But we need to know that we can share information that makes it real robust, and we don't have an opioid fatality review team that's just there because it makes us feel better that we're coming together. So we're really being diligent to say, what is the information that we'll share, and will it give us that extra layer of information? So I just wanted to give a little bit more detail on that, because I think it's real important. We all realize that, and we are meeting with state folks in between and identifying funding resources and support from the state. They may have some movement generally on that end that can really help boost what we want to do here. And lastly, I just want to remind everyone, just in terms of, I love what we shared around self-care, and I've been thinking about it so much, but you also know that I'm very data focused and research focused, and want to remind everyone that there will be research coming out. What I'm hearing lately is like within the next 3 to 4 months, we'll start seeing research about the pandemic and about people and why, and all these questions. And when we, in every kind of situation that we're looking at, people are understanding what is the impact. So there are researchers across the country. Of course, there are some here at Penn. That's why I'm sort of familiar with down in Philadelphia. There's some researchers there that are doing that type of specific research that will be published. So there's nothing out there yet, but I can tell you that some of the early studies that are being discussed and will be also put out there is studies that link what we knew before to what happened during a pandemic. And that is some of the basic things that more than likely we're going to see is the importance of physical activity and being outside. So I'm just mentioning that to you because I also think that we all need to practice what we preach. And I think one of the things that I've learned from many of you is the whole concept of take one day at a time, take small steps. What is the advice we always give, our clients, our friends, our family members when we're in a difficult situation? We need to remember to do that for ourselves and think within that context. In my mind, it's really helped me a whole lot. It took me a while to really feel comfortable with that, but one day at a time, small steps, be appreciative of those things that you're able to do in those small steps, so that, again, you just preserve yourself, feel a sense of, hopefulness, which we all should have together. We are a strong community. We've, look at this coalition that comes together. Not every county has this type of support. So those types of things makes me grateful and keeps me going and really makes me want to get up every day to continue to do this type of work. So I'm grateful for all of you. You just fueled my tank by seeing all of you up here in this discussion we have. It is phenomenal, the people that we have in our community to address this, and we're so fortunate to have everyone here. So So thank you again for all coming together today. Keep in touch in between these meetings. If you have things, please contact any one of us on here. People that are on the steering committee, people that are not on the steering committee, you all have ways of knowing how to get in touch with any of us. There's no wrong door with contacting anyone on our team. So thank you so much for taking time. Please take care of yourself. I'm so grateful for all of you. And, keep in mind, we're in a pandemic. That we should be feeling the way we're feeling. So acknowledging it and thinking, okay, this is all right that we're here, and let's support each other with getting to the other side. So thank you so much for this morning. Again, thank you. Special thanks to Chris Glover for her time, and the panel today was phenomenal. They took lots of time to share their knowledge, but they also prepped, even though it's all in the back of their mind. I'm looking at Sandra here, and she can do this in her sleep. A lot of the responses that we need, and so do the rest of the panel folks. So thanks so much to them, and sharing their expertise and commitment has been wonderful. So thanks everyone, and have a good rest of week. See you next time. Bye-bye.